We're present here in the wonderful weather of Kathmandu, Nepal. I'll be presenting about a rapid survey of assessing the novel indicators of universal eye healthcare. And this is the so vision impairment. We all know that the predictive visual acuity is less than 6.12 in the better eye. We call it a mild vision impairment, but many studies on many qualitative studies have shown that it has a notable impact on the everyday functioning of many individuals. And so in November 2020, the 73rd World Health Assembly have they come up with the resolution on IEP, and universal health coverage, and they came up with these two universal indicators. These are basically the ideal proxy indicators to track changes in the availability, accessibility, and the quality of care in the member states. And the word effective coverage B is to ensure sufficient quality to provide visual acuity better than 6.5. And these are the WHO targets which were given to all of us, all of the member states, at 30% point increase the effective cataract surgical coverage and 40% in the effective refractive error coverage. And rapid assessment of visual impairment survey to assess baseline status and progress towards target were needed. And in India, the previous surveys which were done, like graph surveys, they have the data to calculate the effective cataract surgical coverage, but we didn't have any survey protocol to measure the eREC for India. So we need a methodology to calculate the Rabi surveys, and there was a project from WHO in which the RP Center was part of it. And Professor Praveen Mushish, my mentor, is here. He was a principal investigator, and this was we designed a survey to conduct to make a field survey protocol as a population-based study to calculate the effective refractive error coverage and effective cataract surgical coverage among two pilot districts. These were Gurugram districts, Haryana, and Lakshadweep. So I'll be not talking about the results, but just a brief about the surveys. So what was Ravi? We designed this Ravi protocol, and it was rapid, that in the sense that it can be conducted in just 50 to 20 days. And it included all age groups, 6 years and above, and focuses primarily on the prevalence of avoidable visual impairment, which is due to refractive error and aphakia, cataract and its complications, corneal blindness, and all other the posterior segment disorders, including glaucoma, DR, and other posterior segment disorder, which were included as a part of this category. And refractive error in presbyopia, its coverage, spectacle use, and barriers were also being analyzed as we asked for all these details in the survey questionnaire. And the thing was, we didn't need a trained ophthalmologist for this survey, but a trained ophthalmic technician, which we called an optometrist in India, but they could conduct this survey successfully. So the aim of this study was to assess the prevalence and cause of avoidable VIA in the pilot districts, and to estimate the effective cataract surgical coverage and REC, including presbyopia, and to develop a tool to assist in planning for increasing coverage in the country. The objective was to estimate ERC, eREC, eCSC, and to ascertain the visual outcomes after cataract surgery among operated cases, to ascertain the barrier for uptake of cataract surgery, and also to better to see the barriers for the uptake of refractive error and spectacle services as well. So the survey form consisted of two things: the demographic and then the clinical examination. The the A part of the form was the general information, the demographic, the survey area, the cluster code, the individual numbers, gender, age, etc. And the next part was the visual acuity. And in this, we added the unaided visual acuity, the aided visual acuity, as well as the pinhole visual acuity, just to measure the eREC, which was missing in the RAP. And then there was a lens examination. It was with the use of the torch. And then the D section was to ascertain by the optometrist or ophthalmic technician that what they think is the principal cause of presenting visual acuity. It was less than 6/12. And then E section was details about the refraction, that if the person has spectacles, why they don't have spectacles, what was the cause, where they did, where from where they procure that. and then barriers, and then G were the details of the cataract operation. There they get the surgery, whether it was on the private HU, whether the lens was free or not, and what were the barriers. And the last part was the barriers for cataract operation, why they didn't, if they were advised and they have a lens with the cataract, why they didn't go for the cataract surgery. So each survey team consisted of a field supervisor, which was an enumerator. He did the cluster identification, household enumeration and mapping, along with the local ASHA volunteer, and then demographic details and consent. Then there were the optometrist, field assistant, and a local volunteer. So these were the simple survey tools. They each had 660, 618, and 612, the pinhole, the torch, and the near vision chart, which consisted of two optotypes, which were N6 and N40. And this was the flow chart. When we saw the participant in the survey, the section A, the demographic details were noted, and then we go for the section B. Started with the visual acuity, and then subsequently pinhole visual acuity. Then with the in the section C, the Dodgelet examination, and so and so forth. Sorry about the busy form at the survey this thing. And now from the inside, what is the novel about this thing and what we learned about from the survey? I will just highlight these points. The existing RAP survey methodology provided us with the effective cataract surgical coverage and not ERC. That's sorry if I mistake, for the 50%, 50 plus age group. But as it is rational because 80% of the cataracts occur in this age group, it can generate data on ERC, near vision and presbyopia in more than 40 plus. Refractive error occurs in age and myopia is increasing in the age group of 9 to 15 years, which we were missing here. There was another rapid assessment of visual impairment survey. It was a modification of RAP 6, but it was again in the 40 plus population, not covering all the age group population. There was another refractive error study in school children risk survey, which was developed by WHO, but it was accurate and could be conducted in a countries where the school enrollment is very good. And but in all the CRO regions, like country like ours India, the school enrollment are very less, and the school dropout rates are very high. So uh, we thought that a newer methodology, which is the RABI, is valid for all ages and provides valuable information to the coverage of cataract surgical as well as refractive error services in all the age group. And these results from these survey would help with planning and formulating policy planning, which will be contributed toward the universal eye health coverage. So I just want to again highlighted what we learned. One thing that a trained ophthalmic technician, if if they are trained and the pilot, this thing their kappa index was more than point 0.8 after the training, so they can successfully can conduct the survey. There is no need of an ophthalmologist, for leaving their OT and OPD, PB, OPDs to go and do these surveys. Another thing we learned that the involvement of a local volunteer like Asha and other from the villages, it helps a lot because by overcoming the language barriers and the household and these identification, etc. And I'm happy to share that this study was already published in the Indian Journal of Ophthalmology and got the application certificate at this last ABO AIOS. And thank you for your patience this.
Yes, yes, great to see and like to thank you. Great to see Ravi really mature and take it serious. So I don't want it brief updates. I'll just speak badly. Uh, Rob's had eREC for distance from 2021, including the calculation. Yeah, and years.
Yeah, I think the RAF 7 has included everything. Yes, it's jazz walk. Yeah, yeah. But this survey was done. We did have access to that RAF survey till then.
Yes. Children from 6 to 60, the school going age group. So how did you
method at the school. How did you plan cataract collections that specific each year? Sorry, so 6 to school equal up to 60 years.
Yeah.
So they're in pools, like so. What do you?
Yeah, so there was a mechanism for that. Our team, there were two teams doing the survey together, and we revisited the households after the afternoon. We planned that if we found that the children have gone to school, there was a mechanism, like they went back to the household to get their visual equity. We considered this thing in our mind.
So, although I know you just presented the methodology, I would like to know what was the sample size for rabies?
This was 6,200 individuals. 6,200.
What's the dividend you're taken per visit?
Sorry. What's that? Sample size, for the sample size calculation, we took the visual impairments. If we took 30.1%, I believe. 30.1%. I mean, we took from the national surveys, RAB survey. Overall population 0 to 40.
The sample was taken based on the effective cataract surgical coverage. That was the maximum standard by 6 times 600. We also assessed for the effective refractive coverage the previous studies conducted. According to that, sample size required was much lesser. So we did a higher sample size so then cataract surgical coverage and refractive both can be assessed.